And our next speaker is Dr. Melissa Coe from Indiana University.
All right, well, good afternoon or morning. We're almost there. So my case is kind of similar to Kevin's title. My vision's blurred, sorry, Neil, and one of my optic nerves is swollen. I have no financial disclosures, and this is a public service announcement between me and Admiral Akbar. This is our final case of the morning and potential diagnostic trap, and then there's lunch, so hang with me. Okay, this is a 30-year-old gentleman who presented in the middle of the night to the emergency room, complaining of decreased vision of the right eye for 2 days. He states there was pain associated with eye movements, and preceding the vision issue, he had headaches. He also mentioned some generalized fatigue. His other history, no medications, so I guess that rules out the drugs of bugs and drugs. Past medical history and past ocular history, none. Family history, non-contributory, and a remote past history of intravenous drug use. On examination, his acuity was decreased in the right eye to 2400. Color vision was also dropped in the right eye. There was a right relative afferent pupillary defect. Motility was full, and his anterior segment did show +2 anterior chamber cell. Here's the appearance of that right optic nerve, where we can appreciate some swelling superior, nasal, and inferiorly. And his visual fields, where we can appreciate that blind spot is definitely enlarged and moving paracentrally. So I was just going to turn it over to the panel at this point for any comments about the differential diagnosis.
Were there other signs of intraocular inflammation besides the anterior chamber cells? Was it vitritis or vasculitis or pars planitis or any of the other?
Such good questions, Dr. Volpe. No.
There were none.
None.
So, I think if I saw somebody, and I'm thinking about Admiral Akbar here, I'll be dismissive of true, unrelated, obviously, but, obviously people can have two different things. But if you have evidence of intraocular inflammation associated with an optic neuropathy, it triggers a very specific differential diagnosis between the usual suspects of inflammatory causes and infectious causes. And if one of my other colleagues wants to walk through that differential diagnosis, I would certainly be thinking about syphilis and sarcoid as primary need to be ruled out, regardless of anything else on the exam, but there are lots of other things in the differential.
Yeah, you heard earlier today the issue of extensive testing versus non-extensive testing. This is when you combine evidence of an intraocular inflammation with evidence, and make no mistake about it, it's an optic neuropathy, you have an RAPD, you have changes in the disc. So you have an optic neuropathy with inflammation. You're talking about many of the things that Mark tested for in terms of his assessment of optic neuritis: Lyme disease, sarcoid, syphilis, TB. These are things that you have to think of once you see that anterior chamber inflammation. And we as ophthalmologists, at least many of us as ophthalmologists in the room, we're the only ones who are going to see that inflammation. So if the neurologist, unless the neurologist is a card-carrying neuro-ophthalmologist and has access to a slit lamp, that person isn't going to see the inflammation, and that changes the whole ball game, as Nick said, in terms of if you weren't going to work up the patient extensively with routine optic neuritis, this ain't routine.
I'll just throw in one other thing. In my experience, high-risk behavior is high-risk behavior. He has a history of IV drug abuse, and taking a sexual history on this man would be probably a good idea. And I'm not going to call him a gentleman until I've got that history well in the bag.
And I'd also point out, I think there's unique significance to being anterior chamber cells. There are a significant small subset of patients with idiopathic optic neuritis, demyelinating disease, that can have a splash of vitreous cells and some periphlebitis and things that are peculiar to certain HLA types of patients who get optic neuritis and multiple sclerosis. But there's inflammation in the anterior chamber. You have to connect the two, except for the rare circumstances where it's unrelated, which is...
So I think we have an ARS question coming up, so
Yes,
maybe
we
we'll ask
do.
the audience what they think.
All right, so how would you proceed? 1, obtain neuroimaging. 2, perform a lumbar puncture. 3, obtain a chest x-ray. 4, obtain a skin biopsy. 5, initiate IV steroids. Or 6, obtain blood work. I know I gave you a lot of choices. Okay, well, it looks like we were divided between obtain neuroimaging and obtain blood work. All right, we'll go forward.
I think I would have done that as a, which one of these is not true? Because there's probably only one thing on there that I wouldn't consider doing in my first set of steps, which would be a skin biopsy. But
Right.
So the testing results in the emergency room, the patient had a non-contrast head CT, and that was normal. MRI brain study unable to be obtained because of retained metallic fragments. A lumbar puncture was performed that evening, which showed a normal opening pressure. The CSF composition showed the absence of any white blood cells, 2 red blood cells. The protein was elevated at 84 with normal glucose, and the cryptococcus returned negative. Any other comments right now from the panel, or I'll keep
We're
going?
waiting for the blood
I
study.
know you are.
Are you holding back on us?
You know, there are things I didn't even tell you yet. All right, so in terms of the testing results, the blood work obtained, complete blood count and metabolic profile, unremarkable. A very elevated sedimentation rate and C-reactive protein. An ACE level returned normal, the HIV pending, Lyme negative, ANA negative, so there was a little bit of extra testing there as we thought about atypical causes.
But there's one thing that's missing, as Judith said.
Well, hold your horses there, Neil.
Okay.
Hold your horses. Just giving everybody time to catch up. All right. So, question. I know, because we have to draw this out for 15 minutes, so I had to kind of think. Panel, would you treat when you're not sure exactly what you're treating? This is the middle of the night. The person's 2,400. The things you want, you're not going to get back right now.
an RPR?
What are your thoughts?
So are you trying to put time pressure on a neuro-ophthalmologist?
I'm just
This
gonna
is why
say-
we go into this.
Well, this is a true case, true story. I was the fellow. It was the middle of the night, and I had to make some decisions. So
Just because it's the middle of the night doesn't mean you can't wait for the blood test to come back. And there's a really good reason. Like, the most obvious thing that you might treat would be optic neuritis, ordinaire with steroids, perhaps. I think that there are some circumstances where steroids are best not applied until you get the results of your testing back. And this is one of those cases.
Yep.
High risk, BB in the eye. Come on, BB in the eye, IV drugs. Hello.
any other comments from the other distinguished panelists?
I mean, if it turns out to be syphilis, then steroids will make him better while he's waiting for his penicillin. So I don't think I am not concerned by delaying treatment by 24 hours, if that's what you're asking me. But again, not sure that you would have done anything terrible if you did do that.
I think the main issue is to recognize that this is not typical optic neuritis. If you want to treat it with steroids for 24 hours, fine. I wouldn't.
Yeah, I wouldn't.
But I think the key is to recognize this is something different from the standard optic neuritis, and you need to follow through with it rather than simply saying, here's a prescription for 40 milligrams, 60 milligrams of prednisone a day, come back in 2 weeks, we'll see how you're doing.
The audience wants to know if MOG and aquaporin 4 should have been tested.
Well, back in 2009, no. No, it wasn't. It
How
wasn't.
often do we see anterior chamber inflammation
Yeah,
in
I don't know
MOG?
I don't know the
Certainly
answer.
not in NMO, I wouldn't think, but MOG, I don't think so. So again, I think the presence of the anterior chamber reaction is really significant here, and I would not have thought of testing for MOG or MO.
The audience also wants to know, could this just be uveitis and you're seeing just swelling in relation to
Not with that amount of vision loss, really.
Well, and not without cells in the
Vitreous,
in the vitreous.
yeah.
I mean, if you've got an intermediate uveitis and you've got cells in the vitreous, then sure, you could have some mild disc swelling. But that's what Nick asked at the very beginning. Was there any other evidence of inflammation? In the absence of posterior vitreous inflammation, no.
All right. So, Due to optic nerve swelling, he was treated with 1 dose of IV methylprednisolone overnight. This is real world, okay? The next morning, he was noted to have the following on physical exam. So this may be difficult for you to see where you are, but I'm going to get this arrow going. But you can see that he has a macular-papillary rash there on his hands and a desquamating type of rash on his
So
feet.
is he in a general ED, Melissa?
He is in
or an ophthalmic ED?
This is a general ED called HUP. All right. So rash on the body, including hands and soles of his feet, and now he's providing this history the following morning. Oh, that's been there for 6 months. The HIV rapid screen returned back positive due to the presence of the systemic rash, newly diagnosed HIV, history of IV drug use, as Judith was talking about, and RPR TPA serology sent returned back positive. The CSF VDRL non-reactive, and just for those in the audience, that's a very highly specific but not very sensitive test. So up to 70% of cases can return back non-reactive. He was treated with IV penicillin G for 14 days. We did go forward and continue just completion of a methylprednisolone course, and he, 5 days into treatment, showed improvement of his visual acuity, color vision, as well as his anterior segment exam and optic nerve swelling, and at 2-week follow-up, his acuity in the right eye returned back to 20/20. So final diagnosis, no trap to this panel, syphilitic optic neuropathy. Couple take-home points. Manifestations can occur at any stage of syphilis and involve any eye structure. Optic nerve involvement can be unilateral or bilateral and present, as Nick's questions earlier on was trying to get at, whether it's perineuritis, anterior, retrobarbar, optic neuritis, and retinitis vasculitis. The uveitis part, which we've highlighted here, plus the optic neuritis, certainly increases that clinical concern for syphilis. You have non-treponemal tests and treponemal specific. And just as a quick reminder, the non-treponemal, once you're treated, those titers go back down to non-reactive. The treponemal specific tests, once you have tested positive, remain positive. So we use those as sort of right and left hand and obtain both. The LP and CSF studies are the definitive way to be able to diagnose neurosyphilis, and we talked about treatment. The benefits, there's some literature going back and forth. I think the main thing is that treating them, as Neil said, with steroids and then just sending them out and leaving would be bad. There's many reports of worsening, but certainly a brief course. In some instances where the spirochetes are dying, you can, without steroids, there are rare instances of that reaction occurring. And then there's delayed immunity, so one can have re-exposure to syphilis and can lead to reinfection in that initial 3 to 6 month period. So I just wanted to acknowledge my moderator here, Colin, for providing some images here. May the force be with you. Lunch is just around the corner.